Thank you, Mr. Chairman. I'm a radiologist from Ulsan Medical Center, and I'm very happy to deliver my presentation in this wonderful meeting. Let me start my talk from topological location of the aortic root. In this CT image using RACEM technique, simulating fluoroscopy, demonstration of the aortic root is nearly impossible. In the volume rendering image with anterior to posterior view, aortic root is still not visible because aortic root lies behind the right ventricular outflow tract. The aortic root is the centerpiece of the heart. If we remove LV and pulmonary artery, we can notice the aortic root including leaflet attachment site, naders of the aortic sinus here, and coronary artery orifice. The naders of the aortic sinus lies in a plane at angle of 30 degrees from the horizontal plane. In this CT image, showing surgeon's view of the aortic root, we can see the geometrical relationship between cardiac chambers and the aortic root. I'd like to start to review the detailed aortic root anatomy with this beautiful specimen image by Dr. Hyun. The aortic root has been opened longitudinally to display the detailed anatomy. Here is the sinotubular junction. We can notice aortic valve leaflet, a nadir of aortic sinuses, and membranous septum between right and non-coronary sinuses. I will correlate the specimen image with the corresponding CT image. The aortic root extends from the basal attachment of aortic valve leaflets to their peripheral attachment at the level of the sinotubular junction. Of interest, the basal attachment of aortic valve leaflets are located within the left ventricle, not in the aorta. Approximately 2/3 of the circumference of lower part of the aortic root is connected to the muscular ventricular septum, this green line, and the remaining 1/3 is connected with fibrous continuity with the aortic leaflet and the anterior leaflet of mitral valve. If you compare these two images, we can easily notice what is the normal fibrous continuity between aortic valve and mitral valve. Take a look at this muscular outlet in LVOT in patient with congenitally corrected TGA. This muscular outlet is an anatomical feature of morphological right ventricle. Components of the aortic root are sinus of Valsalva, fibrous interleaflet triangles, and valvular leaflet themselves. Using cardiac CT, we can evaluate all these components. Basal attachment of aortic valve leaflet, which are marked as these blue dots, are below the level of anatomic ventricular arterial junction, this yellow line. If we look at this histologic specimen and CT image, you can note that the basal attachment of the aortic valve leaflet to the ventricular myocardium is proximally located relative to true ventricular arterial junction. Thus, aortic root contains at least 3 circular rings, including sinotubular junction, ventricular arterial junction, and virtual ring along basal attachment site of the AV leaflet. Attachment site of aortic valve leaflet forms a crown-like shape or a club-like ring shape. This is very, very famous diagram showing 3-dimensional arrangement of aortic root. If you compare actual image of CT with this 3-dimensional diagram, we can know why actual CT images are so complex. Fortunately, most important image is most simple image here. This is a target image for measurement of annulus size on CT. Interleaflet triangle is an interesting and important structure to understand aortic root anatomy well. As a result of a semilunar attachment of aortic valve leaflet, there are 3 triangular extensions of LVOT reached to the level of sinotubular junction. These triangles are formed on the thin fibrous wall of the aorta between the sinus of Valsalva. Interleaflet triangles between right and left coronary sinus may have potential communication with the pericardial space or the plane between aorta and subpulmonary infundibulum. Interleaflet triangle between left and non-coronary sinus has fibrous continuity with the fibrous trigone and mitral valve here. And interleaflet triangle between right and non-coronary sinus may have potential communication with pericardial space. Interestingly, and it has fibrous continuity with the membranous septum here, potentially communicate between both right atrium and right ventricle. This patient who underwent TAVI using sapien valve with 29 millimeter in diameter showed concealed contrast leakage in right inferior aspect of aortic root. Where is the location of the contrast leakage? There is a concealed rupture from membranous septum between right and non-coronary sinus. In the synecity image, there is a small contrast leakage from the concealed stack to the right atrium is observed. Fortunately, this patient patient is clinically very stable, and there was no interval change of concealed stack size on follow-up echocardiography, so she is followed up clinically. Complete heart block or interventricular conduction abnormality is an important complication in patients who underwent TAVI. So understanding of aortic root anatomy and conduction system is very important. This specimen shows location of membranous septum between right and non-coronary cusp and location of left bundle branch. As I showed you before, using CT, we can observe this area in very detail. Another advantage of cardiac CT is its capability of quantitative analysis. After massive tracing using cardiac CT, we can obtain a 3D shape of each leaflet, sinus, and each commissure like this. Using customized software, we can measure not only annulus diameter, but also quantitative value of leaflet surface area and sinus volume like this. This red area means coaptation area between two cusps. We have demonstrated that there is a geometrical asymmetry in the aortic root, even in normal patients. I believe this quantitative approach might provide new insight for prognostication of aortic valvular disease. Then, how can we evaluate aortic root in pre-TAVI candidate using cardiac CT? Official guideline has been already published from SCCT in 2012. Let me briefly introduce a pre-TAVI evaluation protocol using CT in our institution, conforming SCCT guideline. First step is annulus measurement after semi-automatic assignment of hinge point of each coronary cusp. Annulus plane of CT is generated. Then, maximal, minimal parameter and area of annulus were obtained and provided. Coronary orifice height from the annulus level was also measured, and coronary anomaly was demonstrated using volume rendering technique. Using CT imaging, opening shape of the aortic valve and valvular calcification were also demonstrated. This patient showed bicuspid aortic valve with extensive valvular calcification. And best angiographic angle for valve implementation was simulated using TAVI-dedicated commercial program, like this. Of course, access route was also an important issue, so we evaluate minimal area driven diameter, like this. As you know, accurate sizing of the prosthesis is a very, very important step in pre-TAVI evaluation because both undersizing and oversizing may induce a severe complication as follows. Let me introduce the prosthesis sizing algorithm with cardiac CT in our institution. We are using both the sapien and core valve system. From registry data in our institution, we have found that ratio of device area over CT driven area showed best prognostic power for paravalvular leakage after TAVI when we use sapien valve. In ROC analysis, a cutoff point of area was 6% oversizing. Although oversizing is important to prevent paravalvular leakage, extreme oversizing more than 20% has been known as a predictor for annulus rupture. So we set up the optimal point to 15% area oversizing in SAPIEN system. Here is an example. This patient showed 481 square millimeter in CT, and 20 millimeter device is too small, and 29 is too large. So 26 device was selected. This patient showed 403 millimeter square millimeter. 23 millimeter is too small, but 26 is too large. But there is no device between them. So we selected 26 millimeter with underfilling of deployment balloon. In this case, effective size was 24 millimeter. In case of core valve, we decided perimeter was an optimal indicator for prosthesis sizing from our data. Optimal cutoff value was 10% in perimeter oversizing. So we set the 15% about perimeter oversizing for optimal cutoff value in core valve system. This is an example, very similar with the SAPIEN valve. Perimeter of this patient is 76 millimeter. For this patient, 29 millimeter core valve is optimal. This slide shows a summary of sizing algorithm in our institution. Our cardiologists are using 15% rule in both SAPIEN and core valve system, and cardiac CT applied prosthesis sizing in clinical routine practice. Ladies and gentlemen, this is conclusion of my talk. Cardiac CT provides high spatial resolution data for evaluation of complex aortic root anatomy. In daily clinical practice, cardiac CT can be used as the method of choice for pre-type candidate evaluation, including prosthesis size, aortic root morphology description, and access route evaluation. Thank you for your attention.